Imagine two children, right? Both 7 years old,
Mm.
and they're both showing the exact same signs of distress in a classroom.
Yeah, they're fidgety, they interrupt the teacher.
Exactly. They really struggle to focus on their assignments. So both of them are sent to a clinic for evaluation.
Right.
Now, one child walks out of that clinic with a diagnosis of attention deficit hyperactivity disorder, plus a comprehensive supportive treatment plan.
And the other.
The other child walks out with a label of oppositional or defiant, and they receive absolutely no medical help whatsoever.
Wow.
Yeah, the presentation was identical. So what's the only difference between them? It is the cultural filter of the doctor holding the pen.
It really is, it's a stark, deeply uncomfortable reality of the diagnostic landscape.
It is.
Because, when we talk about medicine, we crave precision. We want the broken bone on the x-ray, right? Where a jagged white line tells us exactly what is wrong.
Yeah, you want that certainty.
Absolutely. But in psychiatry, that x-ray machine just does not exist.
Right. And that brings us to the core philosophy of our deep dive today. Psychiatry is the study of how the brain, the mind, and human experience interact, and, crucially, how that delicate process can go wrong.
Yes.
But that interaction does not happen in a vacuum. It happens in a room, usually between two people who might come from, well, entirely different worlds.
Exactly. Which is why we are exploring the concept of cultural competency in the organization and delivery of psychiatric care today.
Spot on. We are using the foundational frameworks from modern psychiatric textbooks as our guide. And to really grasp this, I want you, the listener, to picture this clinical encounter not just as a simple meeting, but as a border crossing.
A border crossing. I like that. It's a really powerful way to visualize the stakes of this interaction.
Right. Think about the mechanics of it. On one side of the border, you have the clinician, and they reside in what sociologists call the culture of medicine.
Yes, it's a sovereign land.
It really is. It has its own highly specific, often Latin-based language. It has its own rituals, its own embedded biases, its uniforms, like the white coat, and a very strict hierarchy.
And then on the other side of that border, you have the patient.
Exactly.
Yeah.
And they are bringing their own dynamic, deeply lived cultural world right into that clinic.
Right.
Now, if you, as the clinician, are acting as the border guard and you lack the map of their territory, or you don't know their vocabulary, or you just lack respect for their customs, that interaction completely fails.
The border crossing is denied, or worse, it turns hostile.
Exactly. And the diagnosis, the very thing you're trying to figure out, gets completely lost in translation.
Which is why we really need to state up front that cultural competency is not about, political correctness.
Absolutely not.
We are not talking about checking demographic boxes on an intake form just so the hospital administrators feel good about themselves.
Right. It's much deeper than that.
It is a foundational, non-negotiable clinical skill. If a practitioner cannot cross that border, they simply cannot practice effective medicine.
Yeah.
We are going to explore exactly why certain demographic groups are systematically misdiagnosed, why they abandon their treatment, and why understanding a patient's world is an absolute biological and structural imperative.
So before we try to cross that border, we have to actually define what the territory looks like, right? What do we even mean by culture in a clinical setting?
It's a good question.
Because it feels like a word that gets thrown around so loosely that it almost loses its meaning entirely.
It does, yeah. In popular discourse, culture is often reduced to food, festivals, and flags.
Right.
But in psychiatric practice, a cultural group is defined as a dynamic entity. It is a group of people with shared activities, ideas, and traditions, which are reinforced by its members.
And the absolutely critical word there is dynamic, isn't it?
Absolutely. It is not a static museum exhibit. The views and values of its members change over time. They are constantly influenced by geography, by economics, and, by shifting historical narratives.
The literature gives a really stark example of this dynamic nature. If you look at Chinese culture and Chinese American culture in 2014, for instance, they differ significantly from each other.
Yes.
And both of those groups differ entirely from what they were pre- and post-Chinese economic reforms.
Exactly. So if a clinician is relying on a textbook written in 1990 about Asian culture, they are essentially trying to navigate modern Beijing with a map from the Ming Dynasty.
That's a brilliant way to put it. It completely invalidates the idea of learning a culture by rote memorization.
It really does.
Right.
And furthermore, for a long time, federal policies for healthcare in the U.S. were framed primarily to ensure non-discrimination only for minority, racial, or ethnic groups.
But modern cultural competency is intended to apply far more broadly than that, right?
Yes, it applies to any cultural group that encounters limitations in service access.
Give me some examples of those broader groups, because I think people, well, they naturally default to thinking only about race and ethnicity.
Sure. It includes lesbian, gay, bisexual, and transgender communities. It absolutely includes the born deaf community.
Right, because they have a highly distinct language, social norms, and culture.
Exactly. And it even encompasses the profound differences between rural communities and urban communities.
Oh, that's interesting.
Yeah, think about it. A farmer living 2 hours from the nearest hospital has a distinctly different lifestyle, worldview, and relationship with institutions than a stockbroker living in Manhattan.
Yeah, that makes total sense.
Mhm.
But I have to challenge this premise slightly.
Go ahead.
If you are listening to this, you might be thinking, isn't it incredibly dangerous to just assume all patients of one demographic act the exact same way?
Right.
Like if I'm a clinician and I take a seminar on rural culture or deaf culture, aren't I just creating a brand new, slightly more educated stereotype?
Yeah.
A monolithic construct seems like it would spectacularly fail to account for the actual human being sitting across from me.
That is the exact trap that early iterations of cross-cultural medicine fell into. And it is incredibly dangerous.
Yeah.
Treating culture as a monolith erases the individual. And this is where the foundational concept of intersectionality comes into play in modern psychiatry.
Okay, we hear intersectionality in sociology and political science all the time, but translate that to the psychiatric clinic for me. How does it alter a diagnosis?
Well, it is the recognition that a patient doesn't just belong to one cultural group, they belong to multiple overlapping groups.
Right.
And the intersection of those groups is what shapes their specific worldview and their expression of distress. Their cultural identity encompasses socially defined groups that impact daily living.
Like socioeconomic status.
Exactly. Socioeconomic status, professional roles, gender, stage of life, all of it.
The literature provides a really grounded example of this that clarified it for me. They compared the worldview of an unmarried inner-city black male to the worldview of a black father living in affluent suburbia.
Yes, a perfect example.
Yes, they share a racial identity.
Right.
But let's look at their daily lived experiences.
Right.
The inner-city male might be navigating intense economic stressors, hyper-policing in his neighborhood, and a severe lack of access to preventive health care.
Whereas the suburban father might be navigating corporate microaggressions, the pressures of maintaining wealth, and the specific dynamics of a predominantly white neighborhood.
Exactly. They will make sense of the world very differently.
Right.
Therefore, they will respond to and interact with a healthcare provider very differently.
And if the clinician only sees black male on the intake form and applies a monolithic cultural assumption, they have already failed.
They failed before they even said hello.
Yes. Cultural competency training has to recognize that a person's view of their own intersecting cultural identity is the very foundation of understanding their presentation of distress.
So, if that dynamic intersecting reality is the territory we're dealing with, how do we define the actual competency part?
Right.
Because if I'm a hospital administrator, I need something I can actually measure.
Well, the origins of the concept come from a pursuit of non-discrimination and achieving equitable ends.
Okay.
What's fascinating is how differently healthcare views this compared to other sectors. In the education sector, for example, there are fierce, ongoing debates about whether immigrant children should be educated in their native languages or pushed into full English immersion.
But healthcare has a completely different baseline, doesn't it?
It does. Western medicine in the U.S. and the U.K. is predominantly delivered in English, but there is universal agreement, no real debate at all, actually, that language accommodations are an absolute non-negotiable requirement for persons with limited English proficiency.
Yeah, because you literally cannot diagnose a thought disorder if you do not understand the thoughts being spoken. It's impossible.
Exactly. Which brings us to the most widely accepted definition of cultural competency in mental health care, developed by Terry Cross.
Right, let's unpack Cross's definition.
He defines it not as a subjective feeling of being open-minded, but as a set of congruent behaviors, attitudes, and policies that come together in a system, an agency, or among professionals.
Congruent behaviors, attitudes, and policies.
Yes. And that set of congruent elements enables that system or those professionals to work effectively in cross-cultural situations.
I really appreciate that definition because it takes it out of the realm of just, being a nice person.
Exactly.
Demands actionable items. It's not just vibes. And there is a crucial distinction made in the literature between organizational competency and clinical competency.
Yes.
We need to untangle those because I think they often get conflated, which kind of lets massive institutions off the hook.
It is a vital distinction. Organizational cultural competency is about the structure. It refers to the policies and procedures endorsed throughout a department of mental health, a hospital network, or a managed care company.
Right.
It is the framework that enables the staff to actually do their jobs effectively. Do you have a dedicated budget for professional interpreters? Do you have policies for inclusive hiring?
Are your clinic hours accessible to working class populations who simply cannot take a Tuesday morning off work?
Precisely.
So going back to our metaphor, it's the infrastructure of the border crossing. Do you have a bridge built, or are you just looking at the patient and demanding they swim across a rushing river?
Exactly. A clinician cannot be culturally competent if the organization they work for structurally prevents them from being so.
Yeah.
Now, clinical cultural competency, on the other hand, encompasses the personal attributes of the clinicians themselves. And this is broken down into 4 distinct domains: affective, cognitive, behavioral, and skills.
Okay, let's translate those academic terms into the reality of the clinic. The affective domain, which is really just a sterile way of describing a doctor's internal emotional landscape, is about attitudes.
Right.
It forces the clinician to examine their deeply held values and, crucially, their overt and covert biases.
Then the cognitive domain is knowledge. What do you actually know about the social determinants of health? Do you understand the different cultural expressions of distress?
And then skills and actions represent the behavioral domain.
Yes.
You have the right attitude, you have the knowledge,
Mm-hmm.
but how do you apply that in the room to produce a clinically and culturally appropriate service outcome? Can you actually conduct the interview in a way that makes the patient feel safe?
But, we should acknowledge that there has been notable pushback from within the medical community against treating cultural competency as a distinct entity.
Yes, and if you are a clinician listening, you might have had this exact thought.
Yep.
The argument goes, look, I practice patient-centered care. The Institute of Medicine defines clinical competency as using skills to identify each consumer's unique health state, personal values, and expectations. So if I'm doing my job as a thoroughly good, attentive doctor, isn't cultural competency already baked into what I do?
Exactly. The belief is that if notions of recovery, rehabilitation, and empowerment are fully operant, cultural competency naturally follows.
But the researchers don't quite buy that, do they?
No, the counter-argument from researchers is that, for now, cultural competency is simply not treated as a distinct, rigorously tested construct in most clinical training, nor is it adequately represented in medical curricula.
Right.
Until it is universally embedded, it has to be viewed and taught as a distinct, measurable competency, because relying on good intentions is actively leading to failed treatment alliances and devastating misdiagnoses.
Which brings us to a fascinating piece of medical history.
It really is.
How did psychiatry, as a highly academic scientific field, start to realize that its supposedly universal models of the human mind were actually culturally biased?
To understand this, we have to look at the evolution of psychiatric thought, specifically regarding this idea of the culture of medicine.
Okay, let's look at the timeline.
We have to rewind to the post-war social sciences in the 1950s and 60s. Sociologists and anthropologists like Talcott Parsons began studying medical education.
But they weren't looking at the transmission of technical facts like anatomy or pharmacology, were they?
No, not at all. They were studying medical school as a process of professional acculturation and socialization.
They realized that medical school is essentially a multi-year initiation right into a very, very exclusive tribe.
Exactly. What had been taken for granted as purely objective, scientific training was revealed to be an incredibly rich, enclosed cultural milieu.
Yeah.
It was replete with its own rituals, think of ward rounds or the physical examination. It had its key symbols like the stethoscope and the white coat.
And it had its social dramas and intense rites of initiation.
Right, primarily extreme sleep deprivation and public interrogation by senior attending physicians.
Which sounds absolutely terrifying.
It is. But this led researchers to a growing awareness of the culture of medicine itself, rather than just pointing the microscope at the culture of the patients.
Like the old proverb, isn't it? A fish doesn't know what water is.
Exactly.
For a long time, doctors didn't realize they had a culture. They just thought they possessed the objective truth, and everyone else, all the patients, had culture. Recognizing that medicine itself is a cultural construct is a massive paradigm shift.
It was. But it wasn't really until the 1980s that the specific term cultural competence began appearing widely in medical journals.
And that was driven by groups like the Association of American Medical Colleges, right?
Yes. They realized they had to train clinicians to address their patients' cultural identities if they ever wanted to fix the glaring disparities in health outcomes.
And in psychiatry specifically, this caused an absolute earthquake in the Diagnostic and Statistical Manual of Mental Disorders, the DSM.
Oh, massively.
The shift from the DSM-3 to the DSM-5 is wild when you look at it through this cultural lens. The DSM-3, which came out in 1980, aspired to use universally applicable symptom checklists.
Right.
The prevailing idea was major depressive disorder is exactly the same pathology whether the patient is in a skyscraper in New York or a village in Nairobi. Just check the boxes.
But those universal descriptions soon proved to be deeply problematic. They were interpreted entirely differently across ethnic and language groups.
Yeah.
Practitioners realized that applying a rigid Western symptom checklist to a non-Western patient wasn't just inaccurate, it was actively generating false data and leading to harmful misdiagnoses.
So what exactly changed in the DSM-IV in the late 90s to fix this?
A psychiatrist and medical anthropologist named Arthur Kleinman led a special committee devoted to cross-cultural psychiatry. They introduced entirely new diagnostic frames to the DSM-IV appendix, including the concept of culture-bound syndromes. But their most crucial contribution was the cultural formulation.
Right, the cultural formulation.
This was a guide to interviewing and diagnosing patients that fundamentally required the clinician to take the patient's own cultural understanding of their problem into account.
And this was based on Kleinman's explanatory model. I want to spend some time here because it is such a powerful clinical tool.
It really is.
The literature highlights what they call the 3 C's: call, cause, and course. Let's play this out in a clinical scenario.
Let's do it.
Imagine a clinician in an urban emergency room and a patient from a rural, deeply religious community comes in experiencing severe distress.
Okay.
If the clinician just uses a checklist, they might diagnose generalized anxiety. But if they use the 3 C's, they ask the patient, first, what do you call this problem?
And the patient might say, I am suffering from nerves. Or they might use a culturally specific term that translates to a crisis of the spirit.
Right. Then the clinician asks the second C, what do you think is the cause of it?
To which the patient might respond, I have strayed from my faith, or someone in my community has wished me ill.
And finally, the third C. What do you expect the course of this illness to be?
I expect that I will only find peace when I make amends in my community or speak with my spiritual leader.
That interaction fundamentally shifts the power dynamic in the room. It acknowledges that the patient is an expert in their own lived experience.
It does.
If the doctor just prescribes an anti-anxiety medication and ignores the patient's explanatory model, that patient is never coming back.
Never. And around the same time this was happening in psychiatry, psychologists like Darold and Stanley Sue were advocating for similar shifts in counseling, emphasizing the need to understand psychiatric symptoms that could be easily misunderstood across the cultural divide between, say, Western medicine and immigrant patients.
So by the year 2000, medical training programs were scrambling to catch up, and competing models of training emerged. And I think this is where a lot of modern confusion comes from for clinicians. We need to break down the 3 distinct approaches the literature describes: cultural expertise, cultural sensitivity, and cultural humility.
Yes, because they sound incredibly similar, but the underlying mechanisms are radically different.
Let's start with cultural expertise. This feels like the initial, almost panic-driven reaction of the medical establishment.
It was.
The goal was to have medical trainees master vast bodies of knowledge about the beliefs and behaviors of specific cultural groups.
Exactly. The assumption was that you could learn a culture like you learn the Cribs cycle.
Right.
In practical terms, it led to an emphasis on language translation services and the hiring of cultural consultants, members of minority ethnic groups employed to help providers communicate. It relied heavily on the cognitive domain, acquiring facts about the other.
Here's what you need to know about treating a Latino patient. Here's the checklist for an Asian patient. But the flaw there is glaring, isn't it?
Huge flaw.
It risks creating massive new stereotypes
Mm.
and completely ignores the intersectionality we talked about earlier. So the field evolved toward cultural sensitivity. How does that differ?
Cultural sensitivity shifts the focus. The goal is no longer to master bodies of knowledge about specific groups.
Okay.
Instead, the goal is to understand the broader psychosocial context of each individual patient, to ask each patient for guidance in learning what is relevant to them, and crucially, to heighten the clinical practitioner's own cultural self-awareness. It's about recognizing your own biases during the exchange.
Okay, so expertise is outward-looking and relies on memorizing facts. Sensitivity is both inward and outward-looking, knowing your biases and asking the patient.
Right.
But then the literature introduces a third model, which they argue is the most precise and effective mechanism: cultural humility.
Yes.
This feels like a massive ego check for the medical profession.
Yeah.
You're asking people who just spent a decade in highly competitive, expert-driven schooling to suddenly admit they don't know the most important thing in the room, the patient's reality. Where did this come from?
The term cultural humility was actually introduced by pediatricians.
Oh, really?
Yeah. They argued that humility is a far more accurate and clinically useful term than competency. Competency implies a finite skill you can master, like placing an IV or performing a lumbar puncture. Once you are competent, you are done learning.
But humility is different.
Humility conveys an ongoing attitude, a lifelong posture of learning that a doctor must adopt to truly understand the unique circumstances of each patient.
The frameworks outline 3 practical elements of cultural humility. First, lifelong self-evaluation and self-critique by the healthcare provider to root out assumptions that might reinforce stereotypes.
Yes.
Second, actively empowering patients to have a voice in their own decision-making, flattening that hierarchy we talked about.
Yeah.
And third, forming partnerships with communities to advocate for locally responsive healthcare. It's not a destination, it's a constant process.
And that third point, advocating for communities, provides a seamless bridge to the macro mechanism discussed in contemporary psychiatry: structural competency.
Structural competency.
Yes. This is a vital concept introduced by Jonathan Metzl and Helena Hansen.
Let's use a systems engineering metaphor here. Treating depression in a structurally violent environment is like repeatedly bailing water out of a boat, while completely ignoring the massive hole in the hull.
That's spot on.
You're treating the symptom of the sinking, but you aren't fixing the structure. If cultural humility is about the interaction between the doctor and the patient inside the boat, structural competency zooms way out to look at the hole in the hull, the storm raging outside, and the laws governing the waterway.
Exactly. The central premise of structural competency is that health inequities don't just spring from individual biological differences or even individual cultural misunderstandings in the clinic.
Right.
They result from and reflect institutionally embedded inequalities.
We're talking about the profound social determinants of mental health: unstable housing, the threat of eviction, unsafe and polluted neighborhoods.
Zoo deserts where fresh produce is unavailable.
Right? Substandard education and high levels of police surveillance and incarceration. These structural factors physically and psychologically sicken marginalized groups of people.
They do. And the textbooks make a point to situate this evolution within contemporary societal events.
Yes, and to objectively report what the source material states, the authors note the profound impact of events since 2014, where law enforcement agents were involved in adverse community situations resulting in the loss of Black lives.
Right.
They document that the collective response, specifically the Black Lives Matter movement, aimed to eliminate these occurrences and raise public awareness of innate biases and prejudicial treatment within all systems, including healthcare.
And keeping with our impartial reporting of the text, it notes that these societal events prompted private and public organizations, including massive medical settings, to actively put activities in place to ensure their environments are open and respectful.
For example, the text cites NYU Langone Hospital, establishing an Office of Diversity Affairs with a very specific structural roadmap for promoting an inclusive culture of medicine.
Yes. This didn't just mean diversity training. It meant structural hiring at institutional and leadership levels, diversifying faculty, and introducing medical curricula specifically focused on systemic racism and its direct impact on health outcomes.
The ultimate takeaway for the clinician regarding structural competency is a radical shift in their scope of practice.
How so?
Well, traditionally, practitioners are trained strictly in individual patient-level interventions. You treat the brain in the jar, essentially.
Right.
But structural competency argues that clinical practitioners, as highly educated health experts, can and should work with institutional stakeholders to reorient policies. It asks clinicians to collaborate with non-health sector agencies, housing assistance, education, legal aid, to address the root causes of the distress they are treating in the clinic.
So if we accept that cultural and structural competency are foundational imperatives, what actually happens to the patient when that structure collapses? When the doctor lacks humility and the system lacks structural support?
The data paints a pretty grim picture. Let's look at the clinical manifestations of these failures.
To understand the sheer scale of the potential failure, we have to look at the demographic reality of the United States. According to the 2021 U.S. Census figures cited in the texts, 40.7% of the U.S. population is non-white.
That's huge.
That includes 18.9% Hispanic or Latino, 12.6% Black or African American, and 5.9% Asian. And as researchers note, the Hispanic and Latino demographic is likely even larger due to uncounted, undocumented immigrants who will still inevitably interact with hospital emergency rooms and public clinics.
The point being, cross-cultural encounters in psychiatry are not a rare exception anymore. They are the absolute daily norm.
Yes.
Data from the New York State Public Mental Health System back in 2013 showed that nearly half their patients were either Black or Hispanic. If your healthcare system isn't built for a diverse population, your system is fundamentally broken.
And the epidemiological data shows us exactly where the breaks are happening. We have a tragic legacy of sustained disparities that have been documented for decades.
Yeah, going back to the 1978 President's Commission on Mental Health, championed by Rosalind Carter, and the landmark 2001 Surgeon General's supplemental report.
Right. These reports laid bare the devastating disparities in availability, access, and quality of needed services for Americans of African descent, Asian and Pacific Islanders, Latinos, and Native American populations.
But what's truly alarming is that despite those reports over 20 years ago, the source material details studies from 2010 to 2015 proving these disparities are stubbornly persistent.
It's very frustrating.
Let's unpack some of this data because it perfectly illustrates the clinical misdiagnoses we discussed earlier.
Let's examine clinical misdiagnoses closely. When a clinician's cultural filter doesn't accurately recognize a patient's cultural expression of distress, it leads to skewed epidemiological data that harms whole communities.
Can you give an example?
Sure. For example, multiple papers explore the reasons for historically higher rates of diagnoses of severe psychosis, specifically schizophrenia, in Black adults compared to white adults.
We have to pause here and ask the critical question. Is that a true biological difference in prevalence? Or is it a massive diagnostic failure happening inside the clinical room?
The clinical consensus leans heavily toward diagnostic failure.
Unpack that for us.
Think about the dynamics of the room. A Black patient comes in. Perhaps they have a very healthy, historically justified suspicion of medical and governmental institutions.
Which is completely understandable.
Right. Perhaps their cultural style of communication is more expressive, or they hold deep spiritual beliefs about the causes of illness. If a white clinician, operating without cultural humility, misinterprets that justified institutional mistrust as clinical paranoia,
Right.
or misinterprets spiritual beliefs as persecutory delusions, a devastating misdiagnosis of schizophrenia occurs.
The doctor makes a cognitive leap based on their own cultural baseline, and suddenly a patient is put on heavy antipsychotics for a disease they do not have. That is structural violence disguised as medicine. And we see a similar fascinating diagnostic controversy with children. The sources mention historically higher rates of ADHD diagnoses in Black children in national studies.
Right.
But then there's a highly nuanced 2014 study by Siegel and colleagues looking specifically at the New York State Public Mental Health System.
Yes. In that specific public system, contrary to national findings, ADHD prevalence rates were actually recorded as higher in white children, with the exception of Hispanic females.
Why the flip? What is the mechanism behind that data?
It reveals everything about structural access. The researchers reason that white children generally have greater access to private healthcare providers through private insurance.
Ah, okay.
They make greater use of general practitioners and private child psychiatrists for these behavioral diagnoses. By doing so, they are entirely removed from the public system's data pool.
That makes sense.
This highlights how structural factors like who has access to premium insurance completely distort our understanding of who has what disorder.
So we are literally seeing different diagnostic labels applied to the same human suffering, purely because of the clinician's cultural filter or the structural design of the healthcare insurance system.
Yes.
What about access and utilization? What happens when marginalized patients try to get through the door in the first place?
The data is deeply revealing here. A 2013 study by Cook found that Black and Latino populations initiated mental health care far less frequently than white populations.
Okay.
And crucially, when they did initiate care, their episodes of treatment were shorter, and they had significantly fewer psychotropic drug fills.
So they aren't starting treatment, and if they do, they drop out faster and stop taking their medication. We have to explore the why here. It's not just non-compliance, it's a failure of the system to hold them.
Right. Consider a 2012 study looking at Medicare populations. It found that older Black adults were significantly less likely than non-Hispanic whites to receive a depression diagnosis from their provider.
And even if they were finally diagnosed, they were less likely to be treated.
Exactly. For Asian populations, a 2011 study found that limited English proficiency significantly reduced the odds of mental health service use for Latino immigrants, but interestingly, not for Asian immigrants. Yet, Asians overall remained less likely to access care than other groups.
That points to deep-seated cultural stigmas against seeking psychiatric help within those communities, combined with a healthcare system that has absolutely no idea how to reach out to them effectively.
Exactly.
If your outreach materials are only in English and they frame depression as a biochemical flaw rather than addressing the cultural stigma, those patients will suffer in silence.
The literature also highlights systemic structural failures in access for indigenous populations. For Native Americans, a 2012 study noted that the Indian Health Service, the IHS, remains chronically understaffed and deeply underfunded, with very little oversight of mental health services.
Now, we also have to consider the literal geography of care.
Oh, geography's huge.
A 2013 study examined residential segregation. They found that highly isolated Latino areas and areas with high Black concentrations had severe, crippling shortages of psychiatrists.
Yeah.
Residents in Black neighborhoods were largely treated by non-psychiatrists and general doctors for complex mental health issues.
It is the structural competency issue again. You can train the most culturally humble, sensitive psychiatrist in the world, but if their clinic is located 50 miles away from the segregated neighborhood where the patient lives and there is no reliable public transit, their competency is entirely moot.
The patient cannot get to the boat to be saved.
Right. And the psychological toll of these structural issues is profound. Another study looked at women from Latino and Asian American backgrounds. They found that perceived gender and race or ethnicity discrimination negatively predicted their satisfaction with mental health services.
So, if they feel the world is biased against them in their daily lives, they carry that immense mistrust right into the clinic.
Yes.
If the doctor doesn't address it, the alliance is dead on arrival.
Okay, so we've mapped the territory. We understand the theory of cultural and structural competency, and we have seen the devastating clinical manifestations, the misdiagnoses, the dropout rates, the systemic geographic barriers when the system fails.
So now we need to look at the blueprint for fixing it. How do psychiatrists in immense healthcare institutions actually build a culturally competent operating system?
The textbooks approach this from two directions: top-down institutional frameworks and bottom-up clinician frameworks.
Let's look at the top-down regulatory backbone first, because these policies didn't just appear out of nowhere. They were fought for, and they have deep legal roots.
Yes. We have to trace it back to the Civil Rights Act of 1964. Title VI explicitly states that no person shall be excluded from participation in programs receiving federal financial assistance on the grounds of race, color, or national origin.
And that was followed decades later by the Americans with Disabilities Act of 1990, which mandated accessibility for psychiatric conditions and pushed federally funded programs to adopt broad competency principles.
Right.
But a major, highly specific turning point for language access occurred in the year 2000 when President Bill Clinton signed Executive Order 13166.
Improving access to services for persons with limited English proficiency, this was massive.
Why was it so important?
It legally required federal agencies and anyone receiving federal funds, which includes almost every major hospital, to implement systems ensuring meaningful access to services for people with limited English proficiency without unduly burdening the agency.
So it codified it.
It essentially codified that ignoring language barriers is a form of national origin discrimination under Title VI.
And that same year, the Department of Health and Human Services published the CLAS standards, the National Standards for Culturally and Linguistically Appropriate Services in Healthcare.
Yes, but the literature notes a critical flaw there.
What was it?
Initially, only the linguistic assistance parts were mandated by law. The rest of the cultural competency standards were just encouraged. They didn't have teeth.
Which is precisely why they had to be aggressively revised in 2013.
Right.
The new CLA standards were augmented with extensive guidelines and organized into major actionable themes: communication and language access, engagement, continuous improvement, and crucially, governance, leadership, and workforce.
That last one is vital. It ensures that cultural competency isn't just a side project managed by a junior HR rep. It has to be integrated into the highest levels of the hospital's leadership.
The texts map this out beautifully. It shows that an organization's policies, its mission statement, its dedicated budget for translation, its hiring practices directly impact the clinical milieu.
Yes.
If the policies legally require hiring diverse staff and providing paid time for training, the clinical team becomes more confident. That competent team then actually uses cultural assessments to choose appropriate clinical tools, which ultimately leads to better, more equitable care outcomes. It is a direct chain of causality.
But the challenge for administrators is, how do you measure if a massive hospital network is actually doing this?
Right.
That is where the Nathan Klein Institute or NKI assessment scales come in.
Ah.
The developers of these scales wanted objective, verifiable measures. They didn't want subjective self-assessments where hospital administrators just say, yes, we feel we are a very inclusive facility.
Right, because as we established, vibes are not a measurable metric. So what does the NKI scale actually measure at the program level?
They list 14 specific criteria, but let's synthesize them into the core philosophies. The first major philosophy is the cultural assessment of the consumer.
Okay, what does that look like?
The scale asks, does the program go beyond standard demographics, age, gender, race, to collect deeply detailed information on cultural group identity, level of acculturation, and religious or spiritual beliefs?
And crucially, is that information actually made available to all clinical staff,
Yeah.
or is it buried in a file somewhere?
Exactly. It's about getting the patient's explanatory model onto the actual medical chart so everyone sees it.
Right.
Another core philosophy is spoken language capacity. Does the program actually have procedures and employed staff to facilitate working with limited English proficiency or deaf consumers?
You can't just rely on a patient's 10-year-old child to translate complex psychiatric symptoms. That is a clinical and ethical disaster.
Absolutely. Another vital area is culturally framed stigma reduction.
I find this one fascinating.
Does the program intentionally conduct activities to reduce the stigma of mental illness as experienced by a specific cultural group? Because the stigma of severe depression in a rural white farming community might look very different from the stigma of depression in a first-generation immigrant family.
The program has to address the specific cultural attribution of the illness to be effective.
Exactly.
And finally, a philosophy I find incredibly powerful: human resources and peer support. Does the program include peer staff people with lived mental health experience from the exact cultural group served by the program?
Yes, having peers from the same cultural group builds tremendous trust.
They act as vital role models for recovery. They bridge the terrifying gap between the sterile culture of medicine and the patient's lived culture.
So that encompasses the top-down organizational infrastructure. You need the legal mandates, the budget, the professional translators, the peers, and then the inclusive policies.
But what about the lone clinician sitting in the room with the patient? Let's look at the bottom-up frameworks for the individual practitioner.
This brings us back to the Sue and Sue tripartite model we touched on earlier, which forms the foundation for most clinical training curricula today.
Right.
It requires the clinician to continuously develop across 3 axes: awareness, knowledge, and skills.
Let's review those quickly. Awareness is perceiving the self. It requires the clinician to ruthlessly understand their own biases and worldview.
Yeah.
Knowledge is perceiving the other, understanding the social determinants we discussed, and specific cultural views on illness causation. And skills are the culturally interpretive clinical approaches. How do you actually run the psychiatric interview without alienating the patient?
And to measure this at the clinician level, there are tools like the Multicultural Counseling Inventory.
Oh, what's that?
It's a self-assessment scale with strong psychometrics. It forces providers to rate themselves on statements like, when working with minority clients, I am able to quickly recognize and recover from cultural mistakes or misunderstandings, or I am actively involved in advocacy efforts against institutional barriers.
It forces the clinician to hold a harsh mirror up to their own daily practice.
It does. But there's a third element to this integration section that is perhaps the most radical. We have the institution doing its part from the top down, and the clinician doing their part from the bottom up.
What about the patient?
Right. The literature introduces this concept of cultural activation of consumers, developed by Carol Siegel and her colleagues.
I love this concept. We know from general internal medicine that health activation, teaching patients to aggressively advocate for themselves, ask questions about their labs, and understand their medications, massively improves health outcomes.
Yes.
Siegel posited that cultural activation could do the exact same thing for psychiatry.
It is about empowering the consumer to recognize that their cultural information is vital medical data and giving them the specific tools to transmit it to their provider.
It completely flips the traditional power dynamic of the doctor as the unquestioned authority.
Exactly. To facilitate this, they developed 12 specific prompts for patients to use during their appointments.
What's brilliant about these prompts is how they dismantle the traditional medical hierarchy. Let's group them by their underlying philosophy. The first group is about flipping the script on authority.
Right.
The patient prompts the doctor with things like, "This is how I would like to be called," and "These are any negative or traumatic experiences I have had because of my cultural identity."
Just stating that upfront gives the provider a baseline understanding of the patient's worldview and any institutional mistrust they're carrying into the room.
The second group gets to the heart of the illness narrative, drawing heavily on Kleinman's 3 Cs.
The patient is encouraged to tell the doctor, here are the names my cultural group gives for why I am seeking care, and here is what my community thinks is the cause of this health challenge.
Imagine the emotional impact on a patient when they are encouraged to say, "My community thinks I am suffering from a spiritual failing, and they judge me for being in this clinic right now."
Yeah, that's powerful.
The clinician immediately uncovers the massive social pressures the patient is facing. If the clinician knows this, they can tailor the therapy to address that specific community stigma rather than just handing them a pill.
And the final group of prompts focuses on care planning anchored in reality. The patient tells the doctor, here is who from my cultural group might help me, and here are the things I like to do where I live, worship, shop, and socialize with people from my cultural group.
It anchors the recovery in the patient's actual lived environment, leveraging their cultural community strengths rather than sending them back into a void. It is a true shared decision-making model.
And we must acknowledge that this shared decision-making is heavily influenced by macro-level health policies.
Right.
The Affordable Care Act of 2010 expanded access to care for lower socioeconomic groups, including many racial and ethnic minority persons, particularly in states that chose to expand Medicaid.
The Mental Health Parity and Addiction Equity Act of 2008 also played a massive role, requiring large employer insurance plans to cover mental health at the exact same level as medical or surgical services.
Though, as researchers note, this only applied to those in the traditional workforce, so its impact on reducing disparities for the most vulnerable unemployed groups is still a work in progress.
But it highlights the core tenet of structural competency. Health policies debated at the federal level dictate who even gets to sit in the clinician's office in the first place.
Absolutely.
Okay, we have covered a massive amount of ground. We've defined the border crossing, mapped the intersecting territory, looked at the history of medical culture, the devastating failures of misdiagnosis, and the actionable frameworks for success.
We have.
Let's crystallize this for the clinician. What are the key takeaways?
If we synthesize the core messages, the absolute foundation is that culture profoundly shapes how mental illness is experienced, expressed, and understood.
Yes.
Mental health care does not occur in a cultural vacuum. It is deeply embedded in society.
Therefore, true cultural competency requires knowledge, skills, humility, and constant adaptability from the clinician.
Right.
And of those, cultural humility, maintaining a posture of lifelong learning and self-evaluation, is infinitely more clinically effective than attempting cultural expertise, which often devolves into stereotyping and memorization.
We must also remember that explanatory models of illness, those three C's, call, cause, and course, vary wildly across individuals and
They
communities.
really do.
These models must be actively solicited from the patient and integrated into the clinical formulation, not ignored in favor of a universal checklist. Language, migration history, intersectional identity, and lived experiences of discrimination directly biologically influence mental health outcomes and a patient's engagement with care.
And it is not just on the individual doctor's shoulders. Organizations play a critical role.
Yes, absolutely.
Equitable care requires massive healthcare systems to address barriers to access, provide professional language services, and actively financially commit to reducing disparities. Reducing these disparities requires psychiatrists to look beyond the individual patient to the structural and systemic factors sickening their communities. Effective psychiatry requires understanding both the individual and the world that shaped them.
Which brings us to our final exercise.
Yes, before we wrap up, we want to test the clinical reasoning we've just spent an hour building. I'm going to throw a few clinical scenarios your way, and if you are listening, try to solve this in your head before we break it down. Ready?
I like this. Let's see how these theories actually play out on the ward.
Scenario 1. A hospital board decides to mandate diversity training for all staff, but they refuse to allocate any budget for professional translators, telling doctors to just use Google Translate or family members. Based on Terry Cross's definition of cultural competency, where does this institution stand?
Well, they are structurally incompetent. Cross's definition demands a set of congruent behaviors, attitudes, and policies.
Right. Congruent being the key word.
Exactly. You cannot have an attitude of inclusion while simultaneously maintaining a policy that denies meaningful language access. Relying on family members destroys patient confidentiality and leads to dangerous medical mistranslations.
Scenario 2. A newly minted psychiatrist buys a book titled How to Treat Latino Patients. They memorize it cover to cover. When a patient from Argentina comes in, the doctor immediately assumes they hold certain folk healing beliefs and structures the interview around that without asking the patient, which model are they stuck in and what are they lacking?
They are stuck in the outdated model of cultural expertise, and they are entirely lacking cultural humility.
Spot on.
By memorizing a guidebook, they have created a monolithic stereotype and completely ignored the patient's intersectional reality. Humility requires the doctor to evaluate their own assumptions and ask the patient to guide them.
Scenario 3. A patient comes into a clinic in a severely underfunded, highly polluted urban neighborhood, presenting with severe chronic stress and depression. The doctor prescribes an SSRI and recommends taking relaxing walks, ignoring the fact that the patient is facing imminent eviction and their neighborhood has no safe green spaces. What mechanism of competency is failing here?
That is a total failure of structural competency.
Yeah.
The doctor is treating the biological symptom, the brain in the jar, while completely ignoring the institutionally embedded inequalities that are driving the distress. Recommending a walk in an unsafe neighborhood shows a profound lack of understanding of the patient's structural reality.
Scenario 4. A clinician from the 1980s is transported to today. They try to diagnose a recent immigrant using a rigid symptom checklist, completely ignoring how the patient's culture views the illness. Which major psychiatric paradigm shift did this time-traveling doctor miss?
They missed the massive shift from the DSM-3 to the DSM-5 led by Arthur Kleinman. They missed the introduction of the cultural formulation and the explanatory model, which proved that universal symptom checklists lead to misdiagnoses when applied across cultural divides.
Scenario 5. A patient walks into their first psychiatric appointment. Before the doctor can start asking about symptoms, the patient hands them a piece of paper that says, "This is what my community thinks is causing my illness, and this is the stigma I face for being here." What concept is this patient demonstrating?
That is a perfect execution of cultural activation.
Really?
The consumer has been empowered to recognize the vital importance of their cultural information and is proactively transmitting it to their provider to foster shared decision-making.
Scenario 6, the final one. A medical student assumes that because two patients are both first-generation immigrants from the same country, they will respond to therapy in the exact same way, ignoring the fact that one is a wealthy executive and the other is a struggling gig worker. What crucial concept are they forgetting?
They are forgetting intersectionality. They are relying on a monolithic cultural construct based solely on national origin, completely failing to account for how socioeconomic status, professional roles, and daily stressors intersect to shape a patient's unique worldview.
Which brings us to the end of our journey across the border. But before we sign off, I want to leave you with a final provocative thought that builds on everything we've discussed today. It's a question that pushes the boundaries of modern medicine.
It is perhaps the most uncomfortable question for the modern clinician.
We talked heavily about structural competency. If structural competency truly requires us to look at the institutional drivers of illness like unstable housing, food deserts, underfunded schools, and discriminatory policy, does the modern psychiatrist's role now have to extend beyond the four walls of the clinic? Does it have to move into the messy realm of community advocacy and political organizing? Because you diagnose a patient perfectly with all the cultural humility in the world. Is writing a prescription enough if that patient is returning to the exact same toxic, structurally violent environment that sickened them in the first place? It forces us to ask, where does the practice of medicine actually end?
That's a profound thought to end on. Here are the details of this episode.
Cultural competency in the organization and delivery of psychiatric care. Byline. To understand a person, we must understand the world that shaped them.